And now, without further ado, I'm honored to welcome Dr. Brian Goldman, our first plenary speaker. Dr. Brian Goldman has always believed that caring came naturally to physicians, but time, stress, errors, and heavy expectations left him wondering if he might not be the same caring doctor he thought he was at the beginning of his career. In his book, Lost and Found, an ED physician's personal and professional search for kindness, Brian explores the personal, professional, and system factors that cause empathy and kindness to be in short supply in our emergency departments. He'll take the audience on a trip around the world and inside his own brain and personality to find the kindest people and robots on the planet and rediscover his own lost compassion. Please join me in welcoming Dr. Brian Goldman.
It's a long way up here. Hi, everybody. How you doing? Correction to Grant Innes. I could listen to you all day. It's a pleasure to be here, and I have a lot of material I'm going to go through as I talk about my journey trying to condense a book into a fairly short talk. Here goes. Get used to these slides. You're going to be seeing the 4 of these, and I'm going to show them very, very quickly in very short order. I have no relationships with financial sponsors, don't belong to any speakers bureaus, consulting fees. I have no patents, sorry to say, and I have no other whatever that is. Disclosure of financial support for the entire program, you can read that at your leisure. The only conflict of interest today is that I have received funding from CAPE to appear here, and I am very, very grateful for that. And this is the statement by CAPE on their mitigating potential bias, and again, I'm going to welcome you to read that at your leisure. I'm also adding another one. I hereby grant Dr. Ken Milne, aka the SGEM, better known more lovingly as Bat Doc, and anyone else the right to live tweet my remarks as if I could stop you if I tried. However, I do swear by Apollo that I won't finish that sentence, but I will say that foam and FOAMed seriously rock. Those are all in-jokes. If I have a few drinks tonight, I'll explain what it means. My Twitter handle is @NightShiftMD. Here goes. I thought I'd begin with a case. This is the case of a 68-year-old woman with a neurodegenerative disease who's brought by ambulance to the emergency department, and she's at the end stage, pre-terminal. She's unable to speak for herself, and she's not interested in an assisted death. Her family has cared for her at home, but no longer feel comfortable to do so, and they've asked for her to be admitted to the hospital. This is a familiar story for us as emergency physicians. An experienced emergency physician examines her, finds her to be thin but well hydrated on a pureed diet. She has no fever, cough, wheezing, respiratory distress. There's nothing to suggest that she's recently aspirated or that she has pneumonia. And dutifully, the emergency physician refers the patient to the internist on call. However, it takes a long time for the internist to get round to seeing the patient, correctly prioritizing this patient's needs with those of other sicker patients with urosepsis, hypotension, what have you. The slang term for this, which I might have used in my young past, but I don't use these days, social admission, aka failure to cope, dyscopia. I don't like those because they stereotype a situation or a behavior and really say nothing about the person or people involved. But as a lower priority admission, it takes hours to occur, and the family keeps asking the emergency physician when questions. When will my mother get a bed? When will my wife see the internist? When can you approximate the time? And a wise physician knows how to say, I don't know. The problem is when you have to say, I don't know, about 17 times in a row. At one point, the daughter of one of the daughters of the patient asked if the emergency physician had actually made the referral. And at that point, the emergency physician did something uncharacteristic for that person. He snapped at the daughter. And that was that. The patient was admitted. The emergency physician was secretly glad not to have to deal with the demanding family. The woman died in hospital 6 weeks later. Not surprisingly, she was at the end stage of this particular disease. And a few months after that, the emergency physician received a letter from the husband of the woman. The letter accused the emergency physician of being unkind. That, of course, was me. And that's a nice photo, because that kind of distracted, anxious look is one that I often wear in the emergency department. That was my patient. And the thing about being accused of unkindness is this: patients may not know competence. They may guess, but there's a good chance that there's going to be an argument about your competence. But they sure do know kindness and unkindness, and it was clear that I had no feel for that family, no empathy for that family. Now, that happened a long time ago, and to bookend that experience, I certainly knew where they were after my late father. That's one of the last photos of my father, Sam Goldman. And if you can see in the background, that rather austere-looking place, that's his apartment at a retirement home. He absolutely hated living there. It broke his heart leaving my mother in a nursing home, and she too has since passed away. And it further broke his heart and took his independence away to lose his ability to drive and to live in this place, this rather sterile place by comparison. He developed advanced coronary artery disease in the last 3 years of his life, and on the last day of his life, he had severe chest pain. We were summoned to the retirement home. He actually said, "I want to go to bed," and in retrospect, we probably should have let him, but instead, we called 911. The paramedics took him to the hospital, where he rallied briefly, and then he continued to have chest pain. And the internist, not the same one as in the other instance, saw him, knew that he was not a candidate for a coronary bypass, for any kind of interventional cardiology. He had complex three-vessel disease, and said, "We'll manage him medically." My sister and I did not hesitate. When we were asked, we said, "Do not resuscitate or allow a natural death." We got him upstairs to the floor, and around about 10 o'clock at night, he said, "I'm tired. I'd like to go to bed." And he blew kisses at my partner, Tamara, and at that time, I wasn't thinking straight. You see, I'd done a night shift the night before, and I'd been up for about 40 hours at this point in time. But as I walked out the door, I said goodbye, then I took a step towards the door, and I don't know, impulsively, I went back to my father's bedside, leaned over, kissed him on the cheek, and said, "I love you." Now, what is remarkable about that is that that's the one and only time in his life and mine that I said, "I love you." Now, it's not that we didn't love each other, it's that he showed it. He was a man of a certain age, a certain kind of generation that didn't say "I love you," but showed it. Anyway, I went home. I didn't remember my head hitting the pillow, and the next thing I knew, I was being shaken awake. I saw the stricken look on my partner Tamara's face, and I said, "He's gone, isn't he?" And my sister Joanne and I and my brother-in-law Rob went back to the hospital, where we saw he had the most peaceful look on his face. And I'm trying to, as if the struggles of the last few years were finally over, and I'm trying to process this massive change in my life, when suddenly the moment is broken by the arrival of the internist and the night duty nurse. And the internist was obviously nervous in my presence. Was I going to be the doctor's son from hell, asking barking questions? And he spoke in sentence fragments. His blood pressure went down. His heart rate went down. "We tried to reach you." What I noticed at that time was no gesture of empathy. I saw defensiveness, and I recognized it because I had been him. That had been me on many occasions, but I finally understood what it was like for that family so many years before. And these two sent me on a quest to learn about empathy. And let's start with some definitions. There's sympathy and there's empathy. Sympathy is a gesture of concern for another person without feeling what they feel. It's more about how we handle a situation with our distress. We're paying attention to our distress, and I'm going to say this, I've already sort of said it: when you're defensive, it's hard to be empathetic. When you are attending to your own distress or awkwardness, it's hard to be empathetic. And that's an important lesson for you to remember for the rest of this talk, and I'll touch on that at the very end. Sympathy has been metaphorically described as the patient or the person in despair at the bottom of a pit the person extending sympathy at the top of the pit, kind of saying it's a long way down there, sorry for your loss, something perfunctory or superficial. Empathy is very different. Metaphorically, it's being down in the pit with that person in despair, standing shoulder to shoulder with them, and that's the paradigm of peer support counseling that we find in addictions and increasingly in mental health these days, that somebody who's been where you've been is in the best position to empathize with you. But let's talk about the three components of empathy. Some say there are five. Let's make it simple and make it three. Empathy in general is the capacity to use your imagination to put yourself in the place of another person and act accordingly. And there are three components. There's affective or emotional empathy. This is not a great thing for health professionals, for emergency physicians to feel. It's what mom feels watching a child get stitches. That wincing that they're feeling, they're actually feeling their pain. I've heard adult children say that they sat at the bedside of their father or mother as they passed away, and they felt pain in their chest as if their heart would break. And so that's the kind of thing that I'm talking about. That's not helpful to any physician. You can imagine that the orthopedic surgeon who felt the postoperative pain of his or her patients would probably quit doing joint replacements that very day. Cognitive empathy is what we're looking for. That's perspective taking, theory of mind. That's what we want. We want us to be able to understand what it's like to be laying down on a gurney for 3 or 4 days in an emergency department with very little privacy. The third aspect of empathy is called emotional concern, and that's what drives firefighters to run towards the fire, not away from the fire, what drives us to run to the resuscitation room instead of ducking. We want us to have that in abundance. So how do physicians rank? How do they rate when it comes to empathy? Well, there just so happens to be a scale. It's called the Jefferson Scale of Physician Empathy. It's a 20-item questionnaire. The higher the score, the higher the level of empathy. It has been well studied in medical students, and many studies have demonstrated that empathy levels drop systematically from the first year of med school to the fourth year. How do physicians compare to one another? We're a very competitive lot, so we want to know, who's on top of the empathy scale and who's on the bottom. And this is a study of 704 MDs, a 70% response rate, which is pretty good. In this study, if you're interested, women were slightly better than men, approaching statistical significance, but not at statistical significance. Interestingly, psychiatrists were at the top of the scale, probably because they spend more time developing a map of a theory of mind of where the patient is at. They have to theorize. That doesn't mean they show that they care or they're kind all the time, but that they have this kind of empathy, this skill, high skill in empathy. Turns out that radiologists are second last, just ahead of cardiovascular surgeons. And if you interview them, if you do interviews with them, you'll hear them say things like, I like the puzzle, the search for the diagnosis, and they don't mention people, patients, as often as other specialists do. Of course, it's a bell curve, and you might find some very cuddly, caring radiologists and cardiovascular surgeons, and in fact, as they move towards interventional procedures, they have to do a lot more patient care, so that might change. Primary care, you'll be happy to know that family physicians, emergency physicians, general internists, the more generalized you are, the more general your training, the more likely you are to have empathy and show it when you are working in the hospital. So that's empathy. I wrote a book called The Power of Kindness. Part of that was to distinguish myself from the million books on empathy that are out there, but also because there is something about it that I think is worth pursuing. Now, the official definition of kindness is pretty banal. It's the quality of being friendly, generous, considerate, compassionate. Compassionate, of course, is not banal, but being friendly, generous, considerate. It is, I find that a banal definition. Let's look at the English derivation. It comes from an Old English word, kind, which is actually derived from kin or kinship. And that's really important as a clue, because it kind of gets you to my kind versus your kind, us versus them. And the way to get from not caring about somebody to caring about somebody is to find what you have in common with them so that you can turn a them into an us. But there's more to it. There's a je ne sais quoi of kindness that I wanted to explore. And that is the ability to tune into somebody else and give them something that they need. It might be an intuitive best guess, but when you give it to them, they're astonished because that's exactly what they needed. Maybe they didn't know they needed it. And it may be a nice gesture, or it could be a kick in the pants. You could be telling them that their fly is undone, or that they're about to make the biggest mistake, or that they've said something that's really embarrassing to themselves and others, and maybe they need to apologize for it. But to do that, it's not. Somebody said to me, what about the person who sees an older person? As I get older, I start to get a little bit more of this extended towards me, and I'm getting help opening doors. Or, if I have a couple of packages, somebody runs to say, here, let me grab one of your packages. And some people will say thank you, and other people will say, grr, you think I can't do that anymore? The point is that the person who's extending it, this is not a generic gesture. It should be a meaningful gesture to that person, and to do that, you have to empathize. You have to be able to tune in to them. There have been, I think we can establish, this is not a scientific presentation, but I think it's fair to say that patients and families would tell you that there is an empathy gap in healthcare. And I think if we look carefully, we'll find it. It's not hard to find instances of, the one I just explained, the person who's on a gurney for 3, 4, 5 days in the hallway of an emergency department with no privacy except for screens and maybe access to 1 or 2 bathrooms. How often do we actually empathize with a person in that kind of position, or a person who's waited all night for our reassessment? So there are many, many instances of that. And, here are some of the theories, and I'm not putting these out as the reasons, because if I do that, you can challenge me. These are questions I'm asking. Do some medical cultures undervalue empathy? They want it when you're coming into medical school, but as you go through the years, in every other way, do they demonstrate that it's not important? Do they have a false dichotomy of caring versus competence, which is a false dichotomy? You can be both. You should be both. Is it lack of training? Can you actually train people to be empathetic? Or is it just an ignoring of empathy as an important part of our toolkit, not just as health professionals, but as human beings? Technology is an interesting one. If technology automates things so that you can spend more time focusing on the patient, it's good for empathy. If, on the other hand, it forces you to weld your eyes to the computer monitor instead of looking at the patient for nonverbal cues, because the slavish computer system forces you to keep putting in your password or to follow a not human thinking pattern, but a computer algorithm thinking pattern for inputting information, then it's bad for empathy. Time pressure is certainly a factor that I live with. I think all emergency physicians do. And notice I didn't say speed. Speed's not the problem. It's time pressure. It's when you walk into a room and you've got 5 other things you should have done by now, or you're waiting for a call from a consultant. So you're looking at the patient, but you're actually listening for a phone or an intercom message telling you to run to the phone, because if you don't, then that consultant won't call you again for another hour. So time pressure. If you find yourself apologizing to each family as you walk in, I know you should do it, it's good etiquette, but if you actually feel guilty as you walk in, or even ashamed of yourself as you walk in, because you've taken a long time and they've waited, and you see the angry looks on their faces or the bewildered looks, that has to be distracting to your ability to tune into the patient's needs at that moment, because you're defensive. Specialization is another important factor, on the good side, specialization makes us experts in narrow fields. Not us, but the specialists. But on the bad side, it fragments care and responsibility. And this is an example. We're in Calgary, and this is probably the most infamous example from Calgary. This is the story of Greg Price. And it actually it's a 6-year-old story with a contemporary twist now, a very up-to-date twist that I wanted to tell you about. Greg Price died May the 19th, 2012, just a little over 6 years ago at the age of 31. He was a pilot, he was an engineer, he played amateur baseball, he was a doting uncle to his nieces and nephews. 407 days elapsed from a Department of Transport doctor noticing a thickening on one side of his scrotum at the epididymis to his death due to a postoperative pulmonary embolus. The cure rate for testicular cancer is 90-95%. And there was a very famous inquiry, a study which was conducted by the Health Quality Council of Alberta, and it found a litany of issues. Referrals took too long. There was no mechanism in place. If a referral was sent to a physician who was off on vacation for 3 months, there was nobody to send it back saying, or to either send it on to somebody else or to send it back saying you need to get another specialist. There was lack of timely follow-up for ultrasounds and CT scans. There was an urgent CT scan. An ultrasound, what happened was about a year, 13 months into his journey, Greg came to a walk-in clinic complaining of low back pain. He was found on examination to have a mass. He had an ultrasound which showed the mass. The radiologist faxed back the report saying urgent CT required. It took a couple of days for them to appreciate it. Of course, the testicular cancer, which nobody knew about, had spread to the pelvis and to the pelvis. And that CT, which was marked urgent, took 10 days to be scheduled, and another week and a half after that to actually be sent back to the doctor who had ordered it. And that's Dave Price, Greg Price's dad. He's sitting at a news conference to announce the findings of the study. Ward Flemons is beside him from Calgary Foothills. And Dave Price said it well. What Greg Price got was treatment instead of care. He said every doctor did their job, but no one cared about Greg. Now, you know, there were other factors. If he'd had a family doctor, might that have made the difference? And it might have. And the new twist is that the Price family has footed the bill for an extraordinary film which you must see if you have a chance. It will be the subject of next week's White Coat Black Art. And it's called Falling Through the Cracks, which was what we called our radio show when we did it 2.5 years ago. That's exactly what happened to Greg. And what they've done is they've used Hollywood film techniques to try to infuse the chronology with Greg and his story, Greg being the missing element. And I urge you to see this film if you have a chance. And this 29-minute film is not intended for Hollywood. It's intended to educate medical students and residents and allied health professionals, and so far it's having an extraordinary effect on the small number who have had the opportunity to see it. Empathy and burnout are the yin and yang. There are rising rates of burnout among medical students and residents. Burnout is characterized by exhaustion, alienation, withdrawal from work-related activities. A recent study of 100 emergency personnel assessed with that Jefferson empathy scale for physicians, and Maslach's burnout inventory showed high levels of burnout correlating to lower empathy scores. So I said I was going to talk about my journey. And when I was that age, a camp counselor told my mom that I was a breath of fresh air, that I was kind, I was funny, and I was fun to be with, and an empathetic guy. So I wanted to find out what happened to that guy. I want you to realize something. The reason why I want to search is that empathy is hardwired into all of us. We are all hardwired to be empathic. Those are the centers of the brain, the anterior cingulate, the insula, the amygdala. These are the parts of the brain that light up when we are being empathic, when we are induced to feel empathy for somebody else. Many studies have shown that newborns cry when their mothers cry. They do not cry when another newborn's mother cries. They cry when other newborns cry. There is this thing called synchrony that newborns and mothers share, that they instinctively begin to mimic each other's movements, their facial expressions within hours of birth, and then as baby learns how to vocalize, they mimic each other's vocalizations, and then their hand gestures. If you look at people in a bar, a couple in a bar, friends in a coffee shop, you'll be able to see in a second the ones who are really cooking with one another, because their speech patterns will be merging, their hand gestures will be merging, and if you were to do a functional MRI of their brains, they would be in sync. Same thing with therapists and clients. Same thing. They actually mimic each other's hand gestures when the therapeutic relationship is really starting to cook. And there are good reasons why this is hardwired and baked into our DNA. It's pro-social. We would have killed each other eons ago if we didn't have it. But there are some exceptions to the hardwiring of empathy. I'll get to those in just a moment. I had an MRI of my brain to see if I still had the circuits for empathy, and I'll give you those results at the end, so you have to stay until the end. And that's Professor Phil Jackson, who did the MRI, entered me in a study. I'll tell you a little bit about that. There I am on the MRI platform. You see me on the right, fitted with the special goggles, because I was given an experiment. On the ceiling in the MRI suite, above my head there in that middle frame, I was shown a computer screen with faces of people in pain, and I had 4 to 5 seconds to evaluate their pain using a joystick. Far left, no pain. Far right, maximum pain, and anything in between. And I was one of several health professionals recruited, and I was compared to people who are not health professionals. So I'll give you those results at the end. I said there's an exception to empathy. People who belong to something called the dark triad, people with narcissistic personality disorders, psychopathic personality disorders, and Machiavellians. These people actually are unable to empathize in large part because of hard wiring. And to that end, and we're not talking about personality traits, we're actually talking about the personality disorder, the DSM personality disorder. So I went to Western University, where Derek Mitchell, who studies empathy by studying the lack of empathy in psychopaths, and he was one of the first to discover that people who are psychopaths are unable to respond to the distress of others. So, running to the bus stop for an important task, you happen to see along your way a child sprawled in front of their tricycle, crying and screaming. Most people take in the visual information, the sound of the crying. You're looking around. Is mom running? Is there somebody who can take over? And if not, you're thinking, I got to stop. A psychopath actually ignores all of that information as if they're colorblind. It's like a form of colorblindness. It's not evil, it's colorblindness. There are other aspects that make you think they might be evil. So Derek Mitchell administered a test called the Psychopathic Personality Inventory. It's a 154-statement questionnaire. This is not a test of psychopathy. It's a test of psychopathic traits in the general population. And these are people who aren't going to be locked up, who aren't hardened criminals, because some of these traits cluster among normal people. So he gave me that test, and I will give you the results of those at the end. And then I went around the world, starting at Tim Hortons. I wanted to meet the kindest people on the planet to learn their secrets. And I was told, leave the hospital because there's a lot of challenges to empathy, and I've explained a lot of them up until now. And when I went to my first Tim Hortons, I met these two individuals, Mark Wafer on the right and Clint Sparling on the left. Mark Wafer, when I met him, owned 6 Tim Hortons restaurants, and they were the most profitable 6 Tim Hortons until he sold them in the entire system. When he bought his first Tim Hortons back in 1996, the first person to walk in the door, it was mostly fully staffed. He still needed to hire some new people. The first person who walked in was Clint Sparling. You can see that Clint Sparling has Down syndrome. And Mark did not know if Clint could do the job. Up until then, he had spent most of his time in sheltered workshops, which have since been banned in the province of Ontario. But he said to me, and he said to himself, if I don't give him a job, nobody will. He'd never worked until that day in his life. So he set up a training program with Community Living Toronto. Clint had to be taught a lot of life skills, had to be taught the job skills, had to be taught how to use the public transit system. And about 3 or 4 weeks later, he graduated and started working at Tim's, emptying garbage cans, cleaning tables. And gradually, he took on more and more responsibilities. And gradually, Mark recognized that Clint was not his most challenging employee. He was his best employee, because he arrived early and left late. He wore his uniform with pride. He was great for the customers. He was great for coworkers. And so Mark hired another and another and another of various kinds of challenges, and would basically say, here, show me how you're going to be able to do this job if you can't hear or if you can't see. And in time, he saw something. He began to make the economic argument for being an inclusive employer. Go to a Tim Hortons or a Starbucks or a McDonald's, what have you now. Take a photo of all of the people working there. Come back in a year, they'll all be gone. The turnover at most fast food restaurants is 100 to 125%. What Mark discovered is that the turnover at his Tim Hortons was 55%. First of all, the people with challenges tended to be so happy there they didn't want to leave, but it also had an effect on the people who did not have challenges. They too wanted to stay. And so if you sell the same double-doubles and donuts and you have a lower turnover, you're going to make more money because it costs $4,000 on average to recruit, equip, train each new hire. So that's the economic argument. But why the heck would Mark Wafer have taken that first risk? Well, easy. Mark was born deaf. And he knew his entire life what it was like to be bullied and even beaten for his deafness, embarrassed by teachers, embarrassed by his principal. And he carried on through life. He developed an empathy for people who were hard done by, people not with disabilities, but people who had been discounted because of their disabilities. And he tells a wonderful apocryphal story of working as a service manager at a car dealership. And the service manager has to be a maven of empathy because you know when your car breaks down, maybe you had to wait for a tow truck, your day has been shot, you may be looking at $2,000 in repair costs, and Mark was adept at empathizing with those customers, and they trusted him when he said it's going to cost $2,000 to fix your cadiddle. But he had one problem. The time when he was doing this job predated email, and he had to close the deal by phone. He couldn't do it. He got his manager to close the deal. One day his manager went to the CEO and said, either Mark goes or I go, and the CEO very wisely fired the manager and promoted Mark to be the manager. Maybe not wise because he soon left and owned his Tim Hortons. So the lessons from Mark. Mark says he would not have been particularly kind or empathic had he not been born deaf, and so it wasn't, but keep in mind, it was not Mark's deafness that gave him empathy for those with disabilities. It was being discounted because of his deafness that gave him empathy for others who had been discounted. From there, I moved on to New York City, September 11th, 2016, the 15th anniversary of 9/11. And I was in that crowd looking towards the plaza, but not allowed to go into the plaza. And if you turn 90 degrees to your right, you see this bar called O'Hara's. And you walk in, and the first thing that you notice is that there are 7,000 or 8,000 crests that have been stapled to the walls, nailed to the walls by first responders from near and far, many, many from Canada. I met a couple of first responders. That's Paul Fisher, who worked in the Monmouth County Sheriff's Office. He was recruited along with his son following the collapse of the Twin Towers to be on the bucket brigade, which you can see in the bottom left. So for about 96 hours, he helped to clear debris. It took about 9 or 10 months to finish that job. And he comes back to this bar every year to reconnect, to form that connection that's what drawn people today to CAPE and does every year. Then I met Robert McGuire in his beautifully pressed firefighter suit. He was arriving downtown just as the second tower fell. He was able to save himself by going into a church, and he worked at Engine 10, Ladder 11, which was the fire department where 300 firefighters went into the building and lost their lives. And in fact, Robert McGuire was on the bucket brigade when they found the remains of his 31-year-old nephew, who had been a probationary firefighter and was on his first job when he was called into the Twin Towers and lost his life. He too comes there every year. He says, this is the place to be. And so it's the kindest bar in the world, and I wanted to meet the kindest bartender at the kindest bar in the world, and that's Paul Macon, who I saw him in action. He can track the moods of 25 customers. He makes sure singles aren't harassed. He puts two single people together, even though they may never talk to each other. He breaks up fights. He saves marriages. He knows when to serve another drink and drive somebody home and when to cut somebody off. and his annual $1,500 Christmas gift in lieu of presents to the family once saved a life. I can explain that later over drinks. And what's interesting is that he wasn't born deaf. In fact, he started working at O'Hara's when it was part of the financial district, the Wolf of Wall Street, and then the Twin Towers fell, and you can see, what happened, and that's a picture of O'Hara's the day after 9/11, and that's Mike Keane in the bottom right, part of the repair crew. And Mike Keane and Paul Macon decided to reopen the place. They reopened 6 months after 9/11, and at the 1-year anniversary, something magical happened. One of the regulars there were a lot of first responders that came there that night. One of the regulars ripped the crest off of one of the first responders and tacked it to the wall, and then another, and by the end of the evening, there were 250 of these crests tacked to the wall, and it's only grown since then. And the lessons that I took from Paul and Mike, some people are born empathic, others have empathy thrust upon them, but the key is to recognize your circumstances, and when they present you with an opportunity to be kind, which is what he did when he accepted this mission, and now this bar has become a mecca for people who were first responders who want to remember what it was like to be there. I went to Japan, where 27% of people are age 65 and older. They have small nuclear families. They have a falling birth rate. And the government is believes it's still the 1950s, that one parent will stay home to look after, one adult will stay home to look after ailing parents. They won't because they're all working. That man that I met there, Tomio Hasegawa, one of 25,000 retired day laborers. He's the last of 8 siblings. He has countless nieces and nephews who he will never meet. And when he dies, his body will probably not be claimed. He is receiving care. His family consists of the personal support worker who comes 3 times a day and considers it an honor, even though it's one of the lowest paying jobs in Japan, just like in Canada. And that's one of the reasons why in 2025 Japan will be 1 million personal care aides short. And you won't be surprised if I tell you that that's one of the reasons why the government, private industry, and academia have developed this multi-billion-dollar moonshot to develop robots. This one's called Twendy1. It can butter bread. It can lift a senior in and out of a stretcher or bed, or in and out of a car. The problem with that, there's 2 problems. One, it costs $250,000 US, so it's a concept car. The second is that it can't adapt to the changing needs of a senior who, when they first hooked up together, weighed 70 kilos and now weighs 55 kilos. And so the lift that was appropriate when they were 70 kilos might actually harm them at 55. So right now, Shigeki Sugano is developing a new model, which is interesting because it's one we know about. It's based on occupational therapists' relationship to clients. So this new Twendy1 will use AI or deep learning to train the robot to adapt to the needs of the senior as their needs change. I found that there was an abundance of social robots. This one's called Telenoid, and at a long-term care facility in Sendai, agitated seniors with dementia sunsetted and were up crying all night until a strange robot appeared, which looks a little like a Teletubby. It's a toddler's body with a toddler's face. It has rudimentary arms that are like flippers, and it kind of ends in hips. And it is teleoperated, which means it speaks thanks to a nearby caregiver. And I want you to see. So that caregiver with her hand over her mouth is going to be the voice, and you're going to see how it works. Play it, please. So you have to click on if you can. If you can't, let me know. Yep, that's it. So the social worker is talking, and the words are coming out of the telenoid. This was one of the sunsetting seniors. She's singing along. And this is something she would not have done before. And here's another one, just like that. She's actually talking to the robot. You can stop it now, or I can move on to the next slide. What I learned from those roboticists is that I think they think more about empathy than you and I because they have to try to simulate it. CareBots are far away from helping seniors, but social robots are being used right now, and they work because they stimulate the seniors' instinct to care for small children and pets. I know that I'm running out of time. At Country Meadows, I saw another gesture of empathy. One of the things I noticed, first of all, is that they have an incredibly calm atmosphere. They have almost no agitation. This is for Ken Milne's benefit. No physical restraints, no quetiapine, no B52, no droperidol, no ketamine. They also don't redirect people who are 90 and say they're about to see their grandma when grandma passed away decades ago. They don't say, oh, she'll be here in a minute. They don't say, here, have a cookie. They don't say she's dead, which wrenches them back into the new reality. So how do they do it? They do it by something called validation, which was developed by Naomi Feil, who you see on the right. Naomi Feil developed a method to connect with people at end-stage dementia. And you know those gestures when you walk into a nursing home and somebody's banging or saying things repetitively? We think they're meaningless, sometimes, especially if they're in a language that we don't understand. But she hypothesized that those behaviors symbolize unfinished core personal issues and that caregivers can help them resolve those issues, which come to the fore as they become disoriented from the here and now, and that's what makes them agitated. So help them resolve it by acknowledging what they're feeling, empathize with them, and the agitation decreases and it lessens the intensity of those behaviors. So how did she get this great idea? Well, she was born in Nazi Germany. She moved with her parents to New York and then Cleveland in the late 1930s and lived in a nursing home where her best friends were people who lived in the nursing home, who were residents. And she developed empathy for them in that way. That's her story. And she taught, that woman that you saw in the first slide of Country Meadows, Lori Quick. This young woman has empathy off the charts. In fact, she's clairvoyant. And on the day that Red Lion Junior High School, James Sheets pulled a gun on Eugene Segro, the principal, and shot him and then shot himself, she actually had a feeling it was going to happen. And she felt bad because she was late for school deliberately, and she wanted to be able to make a difference in the future. And she found that by learning validation, especially centering herself, she was able to go into an all-night grocery store, see a gunman, talk him down by using validation until he left the room with nobody harmed. Pretty incredible stuff. So what I learned from them is to empathize with others, slow down, get centered, and if you feel as if you have a destiny that you've been avoiding, stop avoiding it, which is what Lori had been doing up until then. So I wanted to tell you my results, my functional MRI. This is a set of images, and in fact, I have an underactive empathy center. And like many health professionals, I tend to underestimate the pain of my patients, and I'm not unique. A number of studies have found this. We don't know the reasons. Maybe it's because we're constantly comparing patients to others we've seen, or maybe we're becoming opioophobic. We're afraid that if we acknowledge somebody's severe pain, that it will require a script for opioids. Here's my personality, PPI. I scored at the 15th percentile for cold-heartedness, and as Mitchell said, people like me are of the cuddly types. I also scored, though, at the 86th percentile for Machiavellian egocentricity and the 86th percentile for social influence, which means I'm good at getting people to do things when I want them to do them. That made me feel ashamed of myself. The same kind of shame I feel when I make medical mistakes. Not guilty, shame. Not that I did bad, but that I feel bad. And I just want to take a minute to explain this. If you have hidden shame that you don't know about, you may never know about it unless you make a terrible mistake in the emergency department or elsewhere. The thing about shame is that you're so tuned into your own distress that cognitive empathy becomes impossible. And I believe that many of us have undisclosed shame that we have never discussed with anybody, but if we did, we might be able to deal with it, and that's what makes us unempathetic. The answer for me, the antidote, is the antidote that Brené Brown talks about, that empathy is a choice, and it's a vulnerable choice. In order to connect with you, I have to connect with something about myself. So if you tell something bad about yourself to somebody you trust, if they say to you, you're still okay, or they share something bad that happened with them, then you make that connection, and as soon as you talk about what you're ashamed of, it loses its power. I want to close by saying the benefits of empathy and kindness for patients and families: they're calmer, they're less agitated, they comply more with our instructions. For healthcare professionals, we'll have higher job satisfaction, less burnout. We'll also have lower stress hormones on the job. Here are some lessons for everybody before I close out. Before you go to work, if you want to empathize with people and you got stuff in your head, clear it by centering, breathing, mindfulness, whatever. Practice smiling. Acknowledge and greet family members, not just the patient, but everybody in the room. Make them all feel good. Fight back against time pressure, whether it's scribes or anything else that can be used. Whenever you're talking to a patient or family, try to sit down and try to slow down. Communication. Imagine what it's like to be the person who doesn't know jargon, trying to understand what you're saying and change your words accordingly. If you're funny, try a little humor. Remember that you're human. Don't be afraid to show it, because they'll always forgive you for your humanity. And if you have errors and things that you're ashamed of, talk about them with someone you trust. And as Ken Milne would say, he gave me a t-shirt yesterday, if you have to choose between being right and being kind, always choose kind. I have immense gratitude to CAPE for inviting me, to Sinai Health System that's nurtured me now for more than 30 years, the Schwartz-Reisman Emergency Center, my wonderful colleagues from SREMI who are here in abundance, we're here in force, and above all to my mom and dad, because they gave me wonderful lessons, and at the bedside I learned more about empathy and caring than I ever did in all of my years of residency and medical school. Thank you very much.
I think we have a couple minutes. Did anyone have any questions that they wanted to ask Brian? I don't think we have microphones out there, so you'll have to make yourself obvious. Okay?
Some Twitter questions for you, Brian. And one was from Damian Rowland, said, do we judge kindness on an N of 1 or 2 people? And when we do that, does that mean we're unkind?
I'm not sure that I understand the question.
So, like, when we're dealing, you mentioned when we're dealing with other specialties that we go, oh, well, they're being unkind or they don't have kindness. And yet we only have 1 or 2 interactions with them, and then we judge the whole specialty.
Gotcha.
Rather than maybe it's just that individual, or maybe that individual is just having a bad day.
Yes, I agree. That trying to judge somebody's overall demeanor or kindness on the basis of one interaction, which we often do, is a mistake. Keep in mind that kindness or empathy at the highest levels of executive function is a choice between my interests and yours. And we are human. We're going to make mistakes. But I guarantee you, if you are less kind than you could have been on your way home, you'll feel it. You may not acknowledge it, but you will feel it.
Any other questions?
I'll stand up again. There was one other Twitter question I got.
Do you want to get the microphone?
Yeah.
It's right there.
So this tweet came from the Brow of Justice, and she said, in keeping with the spirit of making connections here, where are nurses on that empathy scale? Because you had, I think, healthcare workers, and I didn't know if it referred directly to physicians, but she said, where are nurses on this empathy scale?
They are in the same ballpark as emergency physicians, as primary care, as general internal medicine, but I'm not aware of studies that have stratified to nursing specialty. But they tend to see the whole patient, and so they fit higher on the empathy scale than radiologists or cardiovascular surgeons. And the Jefferson scale has been adapted to nursing.
I had 2 questions, actually. You talked about how empathy declines in medical school. Does that continue throughout a residency?
Empathy declines throughout residency as well. And I think it has a lot to do with culture. It has a lot to do with the time pressures that we've talked about. This is just a hypothesis. and it's something that my colleague Will Bynum is looking at. There are a few shame-nicks who are starting to study shame in medicine. Shame, the literature in psychology is replete with data on shame in general population and in academia, but not in medicine. And I suspect that the whole humiliating experience of medical school and residency for some inflames that shame, and I believe that that's a critical factor in making people feel defensive and therefore being less empathic. Now, I suspect that once they get into their own domain and their own practice, it might actually recover, because then they begin to feel more personal power to control their workflow, and their professional lives.
Trends in empathy?
Yes, a number of studies have now seen generation over generational decreases in empathy amongst college students, and they don't know the reasons for that. The speculative reasons, the ubiquity of social media, smartphones. And when I say social media, it's sort of like, do guns kill people, or do people with guns kill people? And that's a political argument, but the idea, I don't believe that social media causes people to be less empathic. But what it does do is, if it substitutes face-to-face contact with friends, dear friends, then that would be detrimental to empathy. And unfortunately, a lot of people growing up believe socially that if they have lots of friends on Facebook, that's what it means to have friends, when people of other generations might know that it was heart-to-heart talks that they had in a basement, watching movies, drinking tea, or smoking weed, or whatever it was. I'm not admitting anything, and I'm certainly not admitting if I inhaled.
Okay, I guess we should end it there.
You think it was crystal meth. You think it was bath salts.
So I want to thank Brian for